This set of episodes was streamed and recorded in between 2020 and 2021. It took me this long to upload them, partly because life happened and partly because I'm a slow video editor. Either way, I hope you enjoy this episode. If you don't, please send it to someone who will.
Am I audible? Do I sound like you can hear me clearly? Why can't you see me?
I can't see you too well, but I can hear you.
Wave your hand. Yes. I see you move. I see you move. It worked. Nobody moved. Nobody moved from wherever they are. Everybody, all of you are in the right place.
This is take 30 of Stories with Shastri, and I have Dr. Anjendra Targe coming on board. He is a consultant psychiatrist at his clinic in Kalyani Nagar in Pune. He's also a sexologist, and we're talking about it's all in the mind. That's the theme we're working with, and trying to learn a little more about what that means. And I'm just going to add him on board. Hello.
Hi Sangamitra. How are you doing?
Good. How are you?
I'm very well. Are you able to hear me clearly? Am I audible?
Yes,
All
you are.
right. Okay.
Could you let our listeners know a little bit about yourself?
Sure. So, my name is Anjendra. I'm a psychiatrist. Okay. I go by the name of Dr. Anjendra Targe. And I have my clinic in Kalyani Nagar. I practice as a sexologist along with psychiatry. And I think, as Sangamitra has already posted in her stories, this is one of my passions, mental health and sexual health, because I believe these two areas form the basis, the very core of what it is to be a human being. And also, these are much ignored areas. So I'm glad that Sangamitra is doing this so that we can talk about this and spread awareness, the much required effort, or that, so to say.
Right. Thank you so much for coming. I know it's been a very busy schedule. We've been trying to schedule this conversation for a while now. So, I want a little more about what it's been like for you as a psychiatrist during the lockdown. Is there anything different about it?
Definitely. Okay. See, the experience, because I belong to the old category of physicians who believe in the physical presence of the patient. Okay.
Right.
The minor gestures, the mannerisms of a person which you are able to see, the visual cues which are much clearer in person. So I was much more comfortable with that, but then
Right.
we have to adapt to a given situation. So, with that, yes, I have adopted the online platform as well. And slowly and steadily, more and more people are getting comfortable and warmed up to the technology platform. As far as the lockdown itself, surely, I think the intensity of the problems that people always had in terms of, let's say, something like anxiety, depression, because this is something which we are not familiar with. And there's a lot of uncertainty regarding the situation. And uncertainty always creates anxiety. So there is a definite upsurge in patients who have an increased anxiety, the severity of symptoms. But then we have been able to cope with it because of online platforms which are available, and our government has made it easier because we can prescribe medications as well online. Yeah.
Right. Are you of the opinion that there will be a consistent pattern that could emerge in the mental health states of, the people who come out of the lockdown?
By consistent pattern, what do you mean?
Like, let's say, for example, claustrophobia, right? The fact that a lot of people have been staying at home for so many months. I, for one, have
Yeah.
not left my house since March. So, do you think there will be some pattern like that where it's either PTSD or it's, feeling germophobia for that matter also? Do you
Yeah.
think that
See,
will?
yeah, surely. See, some of the cases, for instance, you mentioned germophobia, okay, which is, so to say, okay, an element of obsessive compulsive disorder, which is OCD, where patients afflicted with OCD have these obsessive compulsive anxiety regarding catching infections and germs. So yes, in such situation, not so much because we are locked down, but because we know that there's a pandemic going around which can be threatening to our health. That's why such problems are increasing. But if you're asking me in terms of, okay, some of the other mental illness and if it is going to continue because of the lockdown, I will not say. For instance, you mentioned about claustrophobia or any other mental illness. What I believe is what the lockdown has done, it has just brought some of the disorders to the fore with an intensity which was not there before. And in fact, what has happened because of this, I believe treatment seeking has improved because people are now online more than before. They are reading more about mental health. Everybody in the newspapers, on the big media channels, we are talking about how this lockdown is going to create a big ripples as far as mental health is concerned, mental illness is concerned. So people are getting much more aware, and therefore treatment seeking has improved. So when treatment seeking improves, the numbers improve. But that does not necessarily mean that the lockdown essentially is a causative factor in increasing mental illness. What I believe is mental illness has always been there. It is just the lockdown is pushing it further and pushing people to the limits, and more people are seeking help. Something like PTSD, yes, definitely, because of the lockdown situation, people are caught up in their families. You hear numerous cases of domestic violence, physical abuse. So in these situations, yes, then the lockdown can be a specific cause, which indirectly then triggers cases like PTSD, definitively.
Right. So when you speak about the surge in, people seeking help, do you think it's also because now we finally have the time to accept ourselves or try to understand ourselves better and we're not, caught in that bustle of, hustling for that matter? Do you think that's why that people are seeking more help because we have that time to think?
I think so, yes, it's partially true, absolutely. Or because only when you get a little bit of time to reflect on yourself, okay, you hit the pause button, so to say, you slow down, and then you start understanding what is happening with me. Because it's so easy to get caught up into like you said, the pace of life, the fast pace of life, that you don't realize because many of the mental illnesses are slow, insidious killers, okay, so to say, because they don't dramatically affect your functioning as far as your socio-occupational life is concerned. So a lot of people just keep on going, working and functioning, but they don't realize the toll that has been taking up, okay, insidiously, okay, subclinically, so to say, in their body and mind. So this is a good opportunity for people to reflect, yes, and understand what's happening with their body and their mind. And that's why, yes, definitely, I think this is a good opportunity for people to now start realizing that this is as important as any other aspect.
Right. And, it personally speaking, for me, I was diagnosed with OCD at the age of 17.
Mm-hmm.
And it took me a very long time to actually be able to, accept it. And I feel like in the lockdown, I did accept that, okay, this is something I have worked with, this is something I
Right,
have. And, I decluttered about 17 years of, things that were in my house.
right.
And the mind immediately feels better. And I was able to talk about it a lot more. But I want to understand that based on your experience, is it easy for someone to be able to share what's on their mind in the first place?
It's not. Okay. The simple one line answer to your question is that no, it's not easy for people to talk and share about their experiences. There are multiple reasons for that. Before I go there, see, I think it's glad that, see, you're now in this platform sharing your own personal experience about your struggle with OCD. I just saw in the Instagram post that you had yesterday posted, someone commented, okay, this is my psychiatrist. And it was such a heartening thing to see because conventionally people don't go up and say that, okay, I'm going and seeing a psychiatrist. Okay. So now we have started to normalize this fact that, okay, it's okay going to a psychiatrist. Okay. Mental illness is like any other physical illness. So that's great. So that's happening. So coming to the why it is not easy for people. Invariably, when a person is sitting across my consulting table, okay, people they're fidgety, they're visibly and palpably anxious. And they generally start with this question that, I'm doing this for the first time, or I don't know how to go about this, Could you help me with some leading questions? Okay. Now, these are questions not generally asked in any other medical setup. You just go, you tell your symptoms. Okay. So here, why this happens is, like I was earlier mentioning to you, symptoms of anxiety, sometimes depression, or any other mental illness are slowly progressive and they're not affecting your health. And what happens is mental illness is closely tied with the real life events of your life, with how you're living your life. In your, there is so much going in your mind. Okay? There's constantly something or the other going in your head. And then what happens is we don't realize that much of that is happening at an unconscious level. Okay. Now, this is an aspect which many people are unaware. Okay. And this is why treatment seeking is important, because when you get help, okay, the unconscious aspect, the psychological aspects, apart from the biological symptoms, of course, okay, of in the causation of psychiatric illness, start coming to the fore. We bring them out to the open, explore and resolve. Okay. But initially, yes, there's a lot of discomfort because of the stigma attached with seeking help. Going to a psychiatrist until a few years back was always considered that, okay, only crazy people go to a psychiatrist. So that shame, that embarrassment, and it is also tied with, so like I said, that psychiatric problems are invariably linked with your real life events. So real life relationships, aspects about yourself, deep, dark secrets about yourself. So going and talking to a stranger about some of the deepest and darkest problems, some people are ridden with guilt, some people are embarrassed talking about some of the things. So that's why it's so difficult. And secondly, what happens is it is negatively reinforced by a lot of statements by loved ones and family members. And that's why, see, I wanted to call this conversation that we're having, it's all in the mind, because that's what people say to people who are struggling with mental illness, that, come on, it's all in your head, it's all in your mind. Okay, you need to just get over it, deal with it, get stronger. Okay, I mean, you need to be more motivated, you need to be positive. So all these statements are poor understanding of what the minor nuances that are concerned with mental illness. Okay. And that is where people question themselves, that, okay, people are telling me, okay, get your act together, just be positive, talk to people, and it'll be all right. Okay. And that's why you start doubting and questioning yourself, that should I be seeking help, or is it something I'm doing to myself? Okay. So rather than considering what you're going through as symptoms, people start questioning them. And that's why it again compounds the problem. Another aspect, another very important aspect is this new genre of people offering or pretending to be mental health counselors. Okay, so to say, the coaches, the motivational speakers. Now that has become a very dangerous kind of a precedent, because especially, I mean, we all know after the suicide of a celebrity a few days back, okay, Sushant Singh, okay, the social media, the internet was flooded by people, okay, inviting people to text and share your problems. Okay, we know this one example I saw in papers, this fashion blogger called, I think, Santoshi Shetty. She's a fashion blogger and she's charging 1,500 rupees for a chat. So this reduces again, okay, this stigmatizes mental, and it dilutes, okay, what mental illness is, the entire experience, and it increases the confusion in people's minds, okay. And a psychiatrist, a psychologist who has studied the process scientifically, okay, understand what mental illness is and how to treat with it. So random people offering help, okay, again contributes to the bigger problem, and that's all comes to the basic question that you asked me, that why it's so hard for people to share.
When you said, it's all in the mind, there are, I see it as how you see it also, but then I also see it as when someone has overcome something, taking whatever, using whatever outlet that they did, they say that it's all in the mind, as a way,
Right.
when they're talking about the solution, not talking about the problem. Right? So is that always productive, or does that prove to be counterproductive sometimes also?
See, it's generally counterproductive because see what does this phrase "it's all in the mind" mean? Okay, and see this is honestly okay of an age-old problem: the distinction between the mind and the brain. Okay, what is the mind and what is the brain? Is our psychiatric problems diseases of the brain, or is there some metaphysical entity called the mind? Okay, which we don't quite understand yet, and how do we demarcate it? That's where the problem lies. And trust me, okay, it's from the ancient philosophers to physicists to modern scientists, physicians. Everyone is grappling with that question. So to answer again that question, that okay, for our practical purpose for this conversation that we are having right now, I won't go into that debate because that's a separate and a big topic in itself, brain and mind. Okay, but I'll tell you what. Okay, there are symptoms. Okay, as far as thoughts are concerned, emotions are concerned, feelings are concerned, which we attribute to the mind. Okay, what is it to experience from the mind? Okay, so for our practical purposes, as far as mental illness and mental health is concerned, if you are having an adverse experience related to your mind or brain, whatever you would like to call, these are symptoms. You remember I was just talking a few minutes back about a restricted life experience, about why people don't seek help and why it's uncomfortable. Because it's such a restricted experiences. Because what happens is some of the symptoms, okay, let me just give you out some of the unusual symptoms which we don't know, which Google doesn't tell you about what depression is, what anxiety is, okay. Symptoms like diminished concentration, memory issues, okay, then issues like diminished pleasure in activities, lack of motivation, okay, lack of zeal, lack of enthusiasm in life, okay. So there is a difference between these things. And people think that I have just changed as a person. I am just procrastinating. I'm just being a lazy person. Or you've been labeled as that. You're labeled as a lazy person. You're labeled as something you're not a go-getter. Okay, you're not doing enough. And we live in this capitalistic society which always demands productivity, efficiency of us. So if you're just having a day off and you're having some time for leisure, you tend to think that I'm doing something wrong. Okay. And that's where this problem comes from. So then this question about being in the mind, if your mind is not functioning properly, if it is in any way, coming in the way of having a good or an optimal life experience, then it must be addressed.
Right. And, there's, speaking of seeking help, or even despite if someone even gets past that restricted lifestyle that they have lived, there's a common stereotype towards therapy that it's always about medication, right?
Right.
And while medication may work for some people, do you think it may not suit some people also?
No, let me first clear this doubt away. Okay, therapy does not mean medication. Therapy in layman language is counseling. Okay. Now there are two people who are qualified to offer therapy or counseling. A psychiatrist also can offer counseling, and a psychologist, a trained psychologist, can offer counseling. Okay. Now, when a psychologist is offering counseling, there is no question of medication because they are not medical doctors and they are not going to prescribe you medication. Yeah. But when the psychiatrist comes with the question, see, for instance, I'll give you an example that how I function. Okay. So I am a psychiatrist. I'm a medical doctor who prescribes medicines on the basis of symptoms that a person comes with, psychiatric symptoms. So when I assess a person, okay, and if there are sufficient symptoms for me to go ahead and start and suggest that you need medicines, I do that, okay? Because like I was telling, these are illnesses like any other physical illnesses, and invariably they require medication. Alongside, yes, therapy is also required because in the etiology, in the causative factors of any psychiatric illness, I strongly believe that there is a strong environmental factor as well, which dates right from your childhood to your relationship to your parents, your personality, your worldview, your financial and your social situation, and real life triggers. So these all constitute the part of therapy in exploring and understanding yourself and giving you more control over how you can alter and change your life. Yes, and the next part of your question was that if medication don't suit a certain person, See, the option is always, ideally, the option should always lie with the patient. So whenever I'm treating a patient, I tell them that why am I starting you medicines and why are they necessary. So it has to be a well-informed decision by the patient. So for instance, I say that, listen, on the basis of your symptoms, I highly recommend that you start medication along with therapy. We are going to start therapy alongside, and this is a gradual process of recovery. Now, invariably, patients ask questions where, will I have side effects? Will I have long-term problems with the medication? So on and so forth, which, by the way, we don't ask about any other physical illness. Again, that has got to do with the stigma and lack of awareness and a poor knowledge regarding psychiatric medication. But invariably, what happens is it's more about the lack of patience on the side of the patients. And why that is, I wouldn't blame an individual patient. It's the society and it's the culture where we have little understanding of how treatment works and recovery works in psychiatric illnesses. Because it's a gradual and a slow process, many times we are not patient enough to wait for the right drug or the side effects to wear off, or to reach that space where you are on just the right dosage of a particular drug, or you are adding a drug, etc. So that process takes a little bit of time, but we want quick results. We are used to get, okay, I have a flu, I have a fever, I have an abdominal pain, also called physical illnesses. I want quick relief. Quick relief, unfortunately, doesn't happen with psychiatric problems. So that's where the problem lies.
Right. So I'm trying to. So there's also a group of people who think that medication, when it comes to specifically psychiatric medication, is a stabilizer rather than a cure. Like, you know, when you have your mood stabilizers, for example. So what's your take on it? Do you think that it should be looked at in that way?
No, it shouldn't. It absolutely shouldn't. See, this particular category of drug, mood stabilizer, so to say, in technical terms, as far as psychiatric parlance is concerned, is basically anti-epileptic drugs. Okay. Now, a drug which belongs to a particular class or category can also function for some other ailment. So these anti-epileptics are what we use sometimes in cases, for example, bipolar disorder or severe psychopathology, etc. But that is never the primary course of treatment anyway. And the other classes of medication, for instance, benzodiazepines, for instance, SSRIs, they are backed by a lot of research into how they play a role in easing out a particular symptoms or treating a particular illness. And I'll tell you, there are so many patients get cured just with the help of medicines with no therapy whatsoever. Okay, right. So cure is possible with medication also. There is absolutely no doubt about that. Yes, there is a lot of work needs to be done because there are still patients who don't quite get the same benefit as others from medication. So yes, I mean, the field is, ever expanding. There is new research happening. Okay, and we don't have 100% cures in, so to say, physical illnesses as well. Not all diabetics are cured. In fact, diabetes is rarely cured. Hypertension is rarely cured. We are only finding now cures for cancer. So similarly, mental health is progressing as far as science is concerned in that direction, and we'll get new and new cures. But as far as do medicines cure? Definitely they can.
Yes, I'm looking forward to what medical research with mental health can show. However, for people who are apprehensive towards medication and as a form of therapy or as something that accompanies their therapy, what are various avenues that are available for them and various outlets that they can choose from?
Yeah, see, the apprehension is what must be attacked first, okay, understood first. The apprehension, see, and I will tell you, I ask this question every time to my clients that are you apprehensive regarding medicines? What kind of misconceptions and notions do you have? Invariably, people have a lot of misconceptions. They might have had a bad experience in the past. Okay, sometimes people just take medicines for 5-10 days and abruptly discontinue, then they develop problems. So this apprehension, we need to first understand where the apprehension stems from. So invariably, the apprehension has no real solid scientific reasons. Okay, but having said that, yes, like I said, the choice is up to the patient. And if they are not comfortable, then yes, rigorous ongoing therapy. There are new forms of therapies these days, like for instance, art-based therapies, which works wonderfully well for a lot of people. Okay, and I'm a big proponent of that. See, lifestyle modifications, yes, go hand in hand, like yoga, meditation, all of that. But many times these are counterproductive. For instance, a person with OCD having intrusive thoughts, his mind is flooded with thoughts, and you are asking that person to meditate. That is, that is like asking a person asking a person to meditate when a house is burning down. Okay, so it's
yeah.
So yeah, other approaches are available, but I believe that still complements to the approach, and we should take a combination and not be aversive to any kind of treatment. There is a modern area of research which I'm really excited about. It is the use of psychedelics in treating, for instance, there is a lot of active research happening with MDMA and psilocybin, which is the no, that's different. Microdosing is different. Okay. There's research happening in John Hopkins University. Okay. I'm following the work of this psychiatrist called as Robin Carhart Harris. So he is the head of the psychedelic research department at John Hopkins. And they are doing a lot of research. Clinical trials are currently going on with the help of MDMA, with the help of mushrooms, psilocybin, which is the active ingredient, in patients of PTSD, in patients of addictions. Okay, so the basis is working on the neural networks which are activated during PTSD and how psychedelics come into the picture. Okay, and there is another new area where psychedelic associated psychotherapy. So to give you a bottom line, under supervised guidance, strictly under supervised guidance. Okay, when a person are given research-based doses of psychedelics, it kind of opens up the wide expanse of human consciousness, and we can reach the farthest and the deepest recesses of the human mind, and maybe surgically extract, so to say, some of the traumatic memories. Okay, so that is how research is proceeding ahead. So yes, times are exciting. Times lie ahead. So there are a lot of options, but as of now, to your core question, the apprehension to medicines must be understood first. Okay, the reasons for the apprehension.
So a friend of mine, actually, I don't remember what the name of the study was, but there was this research that they were doing where they inject something in the nape of the spine, and or the nape of the brain stem somewhere there behind, and that helps cure PTSD almost instantly.
I think you're talking about ketamine. Okay. So ketamine is basically an anesthetic. It's a general anesthetic which causes dissociative anesthesia. But ketamine has shown results only short term. Like you said, it instantly cures PTSD, depression. Okay. But the effects have not been long term, and that's why it's still a new nascent area in research. We don't quite are there as far as using them for general population.
Yeah, I know. I read about something about it being valid for about a year or two at max, and after that you have to just inject it again, which doesn't make sense to me. But
no, not even a year or two, weeks. Right now we are talking in weeks as far as ketamine therapy is concerned. Not even a year or two. I'm not aware of any other kind of injections that you're talking about which gives relief for such a longer duration.
Okay, so I find the article, I'll send it across. So what would you do in a case where patient X, so this could be any patient, where patient X refuses your diagnosis or your treatment?
So see, firstly, as far as how I work, I do not explicitly give diagnosis to my patients. I give diagnosis if patients want a diagnosis. Why that? Because sometimes diagnoses are scary for people, and people read on the internet, people are alarmed. If let's say I give a diagnosis of borderline personality disorder, people go and people read threads, and they are scared and alarmed, and all kinds of anecdotal information, opinions, and they're scared. Okay, and that might throw them out of therapy, and they might just not seek help again. The second aspect is, see, what I do is I try to focus on what is ailing, what is the patient ailing with, and what are the symptoms. So I try to tell my patient, Let's focus on that. Let's focus on the symptoms. Let's focus on your entire life situation and focus on the recovery. Forget about the diagnosis. Having said that, diagnoses are invaluable in many cases because, see, like I told you, many people don't quite understand what's happening with them because of the lack of awareness. I don't know what's happening when I'm not functioning well. I'm tired. I'm not able to focus. I'm not concentrating these days well. I feel tired and lethargic. So when you give a diagnosis, it at least gives them a sense of valid entity, some valid entity that I have something which is a clinically researched diagnosable entity, and I will get better because I know there is a cure possible. So in that way, diagnosis definitely helps. But if a patient does not agree, it's fine. I try to educate them. I need to tell them that, okay, this is what it is, and we are going to work on it, and it's not scary. For instance, depression. 1 in 4 people have depression today. 1 in 5 people have anxiety today. Okay, so it's again comes down to why people don't want the diagnosis. So it comes down to the dialogue and the rapport that needs to be established between the clinician and the patient for them to then start readily accepting. Okay,
Right.
that's how I go about it.
You know, like you said, that you won't diagnose unless they want to be diagnosed. And since therapy or psychotherapy is meant to be very reflective in nature, uh, how much intervention is too much on your part? Like, how much do you think, or intervention of love with doctor? And does intervention always help?
Intervention in what terms?
Intervention in terms of maybe seeking help. So when someone refuses to take treatment, so in that sense, or maybe it could be anything. So intervention is basically seeking help.
Yeah, see, firstly, as far as when you say therapy is a reflective process, okay, there are all kinds of therapeutic approaches available. For instance, the classical analytical therapeutic model, it's explorative, okay, where a person wants to know and explore more about themselves, which they are not aware of, okay. So it's a slow process, and not everybody has the psychological mindedness and the tenacity and the patience to go through that process. So patients have to be selected carefully for such a kind of therapy. On the other hand, there are cognitive approaches like CBT or REBT, which focus on your patterns of thinking and challenging them, challenging irrational beliefs, and then replacing them with new constructive thinking patterns. Okay. So it depends on the therapeutic approach, the specialist, okay, that we're talking about. But as far as treatment seeking is concerned, when the person requires it, but he is not actively seeking, that's a big problem, because in many countries there are laws for it where you have to have forms filled up as far as from the caretakers or the relatives, where involuntary admissions are sometimes required. For instance, in acute psychosis, where a person is a threat to himself or the society, is acting on their hallucinations or delusions. Now, these people require active treatment and they're refusing it. Okay, it requires, but then it becomes a question of ethics. Okay, and that again becomes a separate topic of discussion.
Right. So I want to quickly maybe touch up on how you would deal with a situation like that by asking that what do you do when you disagree with another practitioner's diagnosis of patient X?
Right. Okay. See, what happens is especially in psychiatry, there is a lot of overlap. Okay, but invariably you'll find a patient who has gone to multiple psychiatrists before. Sometimes they have benefited, sometimes they have not. It could be an issue of finances, etc. But when it comes to the not agreeing with diagnosis, I don't really do that. Yes, sometimes, yes, that impulse comes, that thought comes, okay, maybe this was not the right form of treatment or the right diagnosis. But you have to hold, okay, because psychiatric diagnoses sit on a spectrum. Today, a patient who is exhibiting symptoms of anxiety can progress to develop symptoms of depression along with that. A person with depression can have some psychotic symptoms as well. So since psychiatric symptoms sit on a spectrum, symptoms could change, the intensity could change. And that's why it will be foolhardy for me to dismiss a diagnosis that was given by another psychiatrist before and just replace and tell my patient, oh, it's all wrong and this is what we are going to do. So you have to assess
Right.
in the here
Yeah,
and
that
now
makes
what's happening with the person. Yeah,
right. That makes absolute sense. I want
yeah,
to probably move on to talking about, since the only way we can communicate with the world is digitally right now, other
yep,
than telephone. I wanted to ask you about something that's been on my mind for a while, that it's become almost muscle memory to hurl an abuse at someone.
right,
So when you say that, or be abusive towards someone. So when I say that, I also mean internally abusing someone or even yourself, verbally, physically, emotionally. For example, if you're in a social setting at a restaurant and someone just brushes past you without saying sorry, in your
yeah,
head, a lot of people automatically just go, "What a bitch,
right,
what an ass," right?
correct.
Now that has obviously it's a huge spectrum, and there are many extremes to abusive behavior in general. But why do you think it's so easy to do something like that?
See, it has. I think it has got to do. It's a cultural phenomena. It's a socio-cultural phenomena which has progressively and steadily seeped into the aspect of very being. And the concept that comes to my mind is biases. Okay, we all have biases and prejudices. Sometimes we are consciously aware, and the other times, and most of the times, we are not. Okay, it's this lack of awareness about our biases and prejudices is, I think, the key factor over here. Okay, for instance, there are gender biases. Okay, gender biases. Okay, women are supposed to behave in a certain way. They're supposed to be the homemakers. They're supposed to, and we are fraught with stories where women are beaten up by their families. And I used to get so many patients when I used to work in an institute where women were beaten up regularly by their husbands, but they thought that it's okay because it's my duty to serve my husband, and it's okay if he beats me. वो नहीं मारेगा तो कौन मारेगा? So this is the kind of cultural phenomena which makes it acceptable. And when it's acceptable, so when in such an environment, children are growing up, they imbibe what is happening, what is okay and what is not okay, right? So then they grow up with an with with this bias firmly etched into their psyche, and then they don't think doing anything of such kind twice. And as far as the role of internet, yes, definitely. See, what has internet done? It has opened up a plethora of people. It has opened up entitlement. Everybody feels they're entitled to behave in their own subjective manner, use lingo which they feel are comfortable, language which they're comfortable with, let's say a group of friends, a bunch of friends, and they can just comment or share that without any repercussions. Okay, so it is these subjective biases which we are not aware of. It is what has made it so easy for us to just do things and not realize the repercussions that it has on the subject.
Right.
That's
Is
what
it
I
difficult?
that's what I feel. Yeah.
So, is it difficult for you to keep your personal opinion aside when you're talking to a patient,
My personal opinion. See, as far
or
as
your personal set of morals, maybe?
yes, yes. See, as far as personal opinion is concerned, see, my medical opinion as a physician, as a psychiatrist, will always have that kind of a subjective element. But apart from that, yes, there is a body of research and knowledge which I have gained. Being a man of medicine. So as far as that medical opinion is concerned, it's not a problem. As far as the subjective bias, because psychiatry deals with a lot of questions, like you said, of morality and ethics and relationships and real life events. Yes,
Yeah.
but the aspect of something called as there is something called as I forget the term. Okay, so we basically psychiatrists are trained, to not carry their subjective biases in there. Okay, when we are dealing with patients, of course you're going to get an impulse. Okay, sometimes you are repulsed by how a patient is talking, a patient's behavior. Sometimes you develop a quick readily affinity for a person. So these kind
Yeah.
of situation does arise, and that's where the role of reflection, and that's why therapists, psychiatrists also should be, ideally, if they're taking in regular therapy, they should be in therapy themselves as well. to
That's
brush past their own blind spots, okay, to get past the rigidity in their own thinking. So the term I was forgetting, okay, and how could I forget that? Transference and countertransference. So basically, countertransference is basically a reaction that comes to the practicing psychiatrist or the therapist on the basis of the behavior or the words or the emotions that are spoken and provoked from your experiences from the past. Okay, so you have to be constantly doing that work to be not fall prey to such things, okay, so that you are as objective as possible, because that is the number one criteria why people reach out to therapists, because they are supposed to be objective and non-judgmental.
that's true. So how do you, as an individual, not let things that might bother you affect you?
Well, see, like I said, off and on, it's always a good idea, not off and on, okay, whenever you require it, it's always a good idea to seek therapy yourself. And I have myself done that during various phases of my life, okay. Discussing, having a community, having, that kind of colleagueship, okay, to discuss ideas, modern research, and patient cases with colleagues, with supervisors, that is one way. And secondly, detaching from work. That is very, very real principle, not just for me as a psychiatrist, for any person who is engaged, who is passionate about his work. So, some element of detachment, having other passions in life, learning
Yeah.
to be in the given moment, learning to be in the now. Okay, so these are the measures you take.
Right. Unfortunately, mental health care in India is not affordable or accessible. So I was doing some research before our talk today, and I found that the National Mental Health Program that was passed, there are about 18 crore people in India as of, I think, last February this year, who it's a vague statistic, but about 18 crore people who suffer from mental illness or mental disorders. However, the budget that we have as a government with the government is 50 crores.
Right.
So dividing that, that's not even 3 rupees per person.
Yeah, yeah, yeah.
So do you see that changing anytime soon?
See, it must, it has to happen, because see, it's an understatement, I would say, how paltry is the sum that we spend on mental health. See, collectively on health itself, if you talk about health expenditure as far as a percentage of our GDP, you go and search on any good solid platform. It has been lingering from decades now around that one point something to maximum 2% of our GDP. And that's pathetic. That's simply pathetic. Any progressive nation you will compare, okay, even developed nations, I mean, let's not just talk about them, because the healthcare expenditure is anywhere above 8 to 10%. So that's how important health is. And that is one area we have been ignoring. And I have recently read a statistic that if we are spending 1% of our GDP, I mean, the mental health expenditure comes somewhere around, I read a statistic, 0.1%. So you're
Yeah.
right. When you're saying 3 rupees, it comes to that. So it has to change. And fortunately, now with the pandemic, as we were talking in the beginning of session, there's a lot of talk regarding mental health, a lot of awareness happening. So I hope, I mean, I trust the government has to start taking these actions, and the expenditure as far as the infrastructure, having more mental health specialists, having more therapists. Okay. Because that's why there is this notion that therapy is expensive. Honestly,
Yeah.
therapy is not expensive in India. Okay. Any average therapist who is taking ongoing therapy, for instance, in a city like Pune, okay, if I
Yeah.
am taking a 1 hour therapy session, I used to charge somewhere between 1.5 to 2,000 rupees. Okay. So that is how it is. And many therapists charge, for instance, the psychologist who works with me, she charges for an hour 1,000 rupees. That's not too much at all. If we
Yeah.
compare it to physical problems, let's say someone has a medical emergency, someone has a surgery, they will not think twice that, okay, I have to shell out 20 grand for a surgery. They will do it because they will deem it necessary. We don't consider mental health necessary, and that's why we think it's an expense, it's not a necessity. Okay. Secondly,
Yeah.
insurance. The Mental Health Act that has been passed in 2019, that has mandated insurance organizations to include mental health disorders, but it's still not up and running. So there is a big lacuna over there where we do not have that inclusive approach as far as insurance is concerned, health insurance. Okay. And secondly, because government is not spending on the infrastructure, that's why there is less access to people who need it. Okay, we can talk about Pune, cities like Pune and Mumbai, yes, where the middle class, the lower middle class, and the upper middle class has access to therapy. But what about people who cannot afford even such sum? Okay, so that's where the role of governmental organization, and I hope we are having this discussion here, and I'm sure a lot of people are talking about it, and at some point, a big change must happen.
So, moving on towards the concept of sexual health, why is it difficult for us to talk about sex as a whole?
So the thing is, see, I'll start with we should be talking a lot more about sex. We should normalize the talk about sex. These two important aspects, sex and death, are two basic problems that we just don't talk enough about, and there are good reasons for that. But then, because we don't talk about it, that's why we are having so many problems. Okay, mental health problems. Okay, why we don't talk about it? Okay, I mean, historically speaking, okay, there have been phases where there have been societies, there have been cultures which have been very permissive, which have been very open regarding, I mean, our own country, India, the land of Kama Sutra. I mean, if someone has gone to Khajuraho, the temples of Khajuraho, you'll see outside, sculptures with all kinds of, with pornographic structure, sculptures, So we were supposed to be very open and permissive. Okay, what happened then? See, so why we don't talk about it? I think it has got to do with religion. It has got to do with political sanctions. It has to do with power. So in various epochs, various centuries, according to the ideology, according to the religious dogmas and the doctrines followed in the particular country or the continent, according to the cultural necessity for, and according to the people in power who wanted to cultivate a kind of an environment. Okay. I mean, so to say, an Orwellian, a world where you have to tab on the society so that the society does not, unravel, which is epitomized by the 1960s in the US, the hippies culture, which is called as the counterculture, where there was a big revolt, but then it was counterproductive. So why? Because of all these political, religious, and social factors. But we should, because there is no doubt that sexuality sits at the core of the very aspect of the being of humans, and it is tightly linked with mental health aspects.
Yes, you're right. The uh, what is something common when it comes to sexual health in India and how it is treated? I want to understand what we're doing right and where we're going wrong.
Yeah, see, so as far as now, as far as sexual problems is concerned, from the medical fraternity, a lot of specialists practice or deal with sexual patients. Psychiatrists do it, dermatologists do it, gynecologists do it, urologists do it. Okay. So I won't go into the division between the physical and the psychological aspects. Okay. So generally the physical aspects or the organic causes of sexual problems are dealt with the dermatologists or the urologists. I deal with the psychosexual element, which I believe is the strongest and the most important and much ignored element as far as sexual problems are concerned. But it's important. I'll tell you, I mean, there are countless examples which I can give you as far as in what way patients reach out. Earlier, the patients used to just come with complaints, like, for instance, men would come complaints with premature ejaculation or erectile dysfunction. Women, although women wouldn't, and these days more and more women are coming ahead with sexual problems and seeking help. So entities like vaginismus, which is painful intercourse during sex, lack of libido, lack of sexual interests, which is again tied with the psychological aspects. Okay, it can be seen in conditions like depression and anxiety. It can be a relational aspect. It can be associated with the religious and cultural aspect. As we were talking about why we don't talk about sex. I've seen so many people coming to me, so many men coming to me, where they come and tell me that, do you think, doctor, my problem is associated because I used to masturbate in the past. I used to do this sinful activity, which is I've done so many sins and I've done so many wrongs because I used to masturbate. So this cultural belief that masturbation and sex is something wrong Okay, it's so tightly ingrained right since childhood. And why that? Because we just don't talk about it. Sexual curiosity begins at a very, very young age. Okay, in fact, at infancy. Okay, so when questions are asked by children, I just had a patient a few days back where the dad was frantically calling me and he was telling me my daughter, she is 6 year old. And then since yesterday, she suddenly started talking about she's touching her genitals and she's asking questions about, okay, what is that and what. So I just calmed him down. I said, this is a natural part of growing up where kids are going to be curious, okay, and they do. Genital play is common in kids, but it's just that we don't talk about it and we brush it under the carpet. So when questions are asked by kids, parents, okay, instantly the reaction is, oh, no, no, it's nothing. We should not talk about it. Okay, you just go and sleep in your room. So the questions are avoided, okay. And that's where something which is avoided and not spoken about then later assumes a form which is ridden with mystery, with fear, with lack of understanding. Okay, and whatever we don't talk about and we don't have an understanding, we have misinformation. So treatment seeking these days, I see so many couples with non-consummation of marriage, where couples have been married for 4 years and 10 years and 8 years even, where they've not had sex. The factors can be any number, okay, where there it could start with a basic non-compatibility, lack of understanding, lack of experience. I see so many patients these days where, okay, people are just not attracted with each other and yet they get married. This happens in an arranged setup quite commonly. But then, and then they reach out asking, how do I deal with this problem? Now, attraction to a partner is not something which can be cultivated by a pill, right? So these are the aspects which have to be spoken and thought about even before in the early stage of a relationship. So if you were to talk about disorders, there's a different category of disorders which we can use in terms of diagnosis, but the problems mostly stem from poor communication, lack of understanding, okay, and not just talking about sex.
Right. You know, there has been a stark increase. I mean, I only speak out of experience by looking at my social circle, for
Hmm.
example. There's a stark increase in having multiple sexual relationships over a monogamous relationship. And, and it has also changed how we perceive the concept of intimacy. So, do you think it's become better, our understanding of what intimacy is, or do you think it's become worse?
I don't think it's a question of better or worse. I don't think the concept of polygamy, okay, polygamous relationships was non-existent before, and suddenly there has been an upsurge of polygamous relationship. It's just that things were happening under the closet. There is more acceptance, okay, as far as societal changes are concerned. And as far as relationships are concerned, okay, let's not go into what is right, monogamy or polygamy. The simple bottom line is the core idea is whenever, as an individual, you prefer a certain situation as far as being polygamous or monogamous, communicating to your partner is a factor. So if you want to be in a polyamorous or a polygamous relationship, and if you're communicating and your partner is okay with that, though there's no problem with that. And polygamous or polyamorous relationships can be okay, beautiful relationships as well. They can have intimate relationships, very nice relationships as well. So it will be wrong that if we say if polygamy is causing us to lose the meaning of intimacy. The meaning of intimacy can change from person to person. Okay, it is a subjective experience. Okay, and it is an individual experience. Okay, so it has got nothing to do with polygamy. Sorry, I would use the word polyamory rather than polygamy. Okay, yeah.
Yeah, I agree with you. I have been studying about it, understanding it in the past 2 years, and I always thought I was a very monogamous person, but then turns out I'm not, which really helps in a lot of ways, I feel like.
Yeah.
I want to, speaking of, moving on towards sexual orientation. Uh, a lot of people have either inherently know what their sexual orientation is,
Yeah.
and a lot of people have understood it by trial and error. However, is there any other way for the people who don't have the option of experimenting, or when I don't want to use the word experimenting, but maybe trial and error, to understand what their sexual orientation is?
See, honestly, the word trial and error might be a little incorrect here. Why, I'll tell you. Sexuality is, okay, one of those things, again, like mental health issues, which sits on a spectrum. Sexuality is fluid, okay. Many people think, okay, for most of their lives, they are heterosexual individuals, only to discover later in their lives that, okay, they might be having a bisexual or a bi-curious element to it, okay. And whether and what kind of influences affect that, environmental influence affect that, that is up for research. Like you said, trial and error. If I'm if I progress to be an individual who is in a setting where I open my mind to various sexual experiences, and can that affect me in contributing towards, okay, reshaping my sexual orientation? It's up for research, honestly, because we have no statistic, no data on such issues, okay. But I do get a lot of patients questioning this, okay. Invariably the cultural factors come in, okay, because many people know, okay, what their sexual orientation is, and they have realized that at a very young age. But it's these cultural sanctions, inhibitions, and restrictions and questions from family and society which makes them doubt and ends up confusing them. Okay. But the bottom line is sexuality is fluid.
Right.
Okay.
You started this series on your Instagram that's called Mars and Venus. And
Yeah.
I think Mars, Venus, and the Sun, if I'm not wrong.
Yeah.
And where you beautifully speak about, experiences that you've had with people, but you obviously don't reveal who they are, and you wrap it in poetry. So, what made you do something like that?
Yeah. So see, the entire purpose is because I encounter so many people, individuals and people in relationships with problems, mostly born out of ignorance, lack of communication. So I thought this is a good way, this is a good portal in communicating in a very subtle form. Okay. And I am sure a lot of people will relate to that in terms of their own individual or relationship of being in a relationship. Okay. From that aspect. Why I chose Mars, Sun, and Venus? Because see, we associate to certain stereotypes. I mean, I would go out right now and say that it's not very inclusive of me just to divide sex into a binary, okay, because we associate Mars being with the male sex and Venus with the female sex. But my intention was definitely not that, to divide this kind of a situation into the binaries that we are used to thinking, okay, because like I just said, sexuality is fluid, okay, and there are various layers attached to it. So Mars can, define or can be symbolic to any individual, okay. It can be a heterosexual individual, it can be a transsexual individual, okay, and they can relate to that. And I thought this is a wonderful way to reach people where they can relate and understand, and if it connects with them, they will know that they are not alone, and there are many people who might be struggling or having these questions, and it's okay to seek help and get clarity over such issues.
Right.
And
And
sometimes
it's beautiful.
poetry, yeah, and sometimes poetry does a wonderful job in hitting the core in a few lines. Okay, that's why I
Yeah,
love it.
that it does. I really enjoy looking at your page and following up on, the books you're reading, because I firmly believe that you can tell a lot about uh, people based on what they read. And
I agree.
also, it's a lot of fun. So those of you listening, you should check out Dr. Targe's page and, read about the chronicles of Mars, Venus, and the Sun. Moving on, before we wrap up, I have about two more questions that I want to ask you. They're not
Okay.
entirely related to sexual health. It was something I wanted to ask earlier, but I forgot.
Okay.
One is, do you say that there are two ends of a spectrum? On one end, there is education and awareness, and on the other end is ignorance and denial. So, what do you think we as a collective are ignorant or in denial about?
I think it starts with ourselves. Okay. When we think of ourselves, we think that, okay, I, for instance, am a 37-year-old man. I have a set personality. I think in a certain way. I belong to a family group. I belong to a religion, a society, a city. I'm a doctor, etc. Okay. So these definitions, okay, which which make up your identity, if we start questioning them, okay, ourselves, and it starts from there, where what are all these? These are just tags, and these are not essentially, okay, all it takes to exist, okay, as a part of the human experience. So when we start that, then automatically what happens is we are eradicating ignorance about ourselves. We are brushing past our blind spots, okay. We are brushing past our prejudices. We are in awareness of what are our biases, and that leads to the path of the other spectrum, okay, that we are educating ourselves about the right things. We are more aware of ourselves, and okay, my experiences, okay, whatever I experience can be experienced by some other person, and I need to be considerate, and I need to relate the other person as a human being rather than an object, okay. So the other end of the spectrum, we should, if we start with ourselves and being much more aware and reflect on ourselves, our experience as a person, then we can head in that direction of acceptance. See, the best example is, I'll tell you, this Corona situation. Okay, people react to the situation differently. Okay, because the situation is fraught with so much uncertainty, and we as humans don't like uncertainty. We like definitive answers. We like clarity. We like to know what is going to happen tomorrow. So, person who is who hasn't brushed past these things will react to the situation hurriedly. Oh, when am I going to meet my friends? What is going to happen? What does the future behold for me? So you are reacting to the situation. When you are a much more self-aware person, you accept the situation. The acceptance leads to better management and handling the issue in a better way.
Right. Someone just asked whether we could ask questions. You can ask a question by the time I ask my next one, and because
Sure.
Dr. Targe has an appointment after this that he needs to get to.
Yeah.
I think it was Carl Jung, if I'm not wrong, who said that, I could be wrong, who said that science and spirituality at their peak are the same. So do you agree or disagree, or where do you lie on that?
See, you know what? This is a question. See, I honestly agree with Carl Jung, because science definitely does not have all the answers. And I recall a quote by a physicist, Archibald Wheeler. Okay, he's a very famous physicist. So he said that, no, not Wheeler. Sorry, this quote was by Max Planck. Max Planck, the great German physicist. So he says
Physicist, yeah.
that science will never have all the answers. Why? Because science demand observation, and we are the part of the observations that we're making. That's why we can never reach to that objective data we're looking for. And a spiritual experience cannot be assessed by scientific data, by measurement. Okay, and that's where the thing that I was talking to you about earlier, psychedelic assisted psychotherapy. What psychedelics basically do is, in loose terms, so to say, dissolve the ego. The
Yeah.
ego is associated with all these things that we are used to define ourselves by: our name, our tag, our city, our religion. So when you dissolve, and if you are able to dissolve that, you know that you are a part of the entire universe, and you can break down, we are all made up of matter. We probably share one single consciousness. So in that regard, I agree with Carl Jung for sure.
Right. Okay, we have a question that asks, how much of a psychological or mental problem is erectile dysfunction, and how much of it is physical?
See, there are two important things to know here: age, and if there is a physical condition associated with it. See,
Right.
invariably, if a person reaches out to me under the age of 45, and if he does not have any other physical problems, like let's say diabetes, hypertension, taking any other medicines, then it invariably is a psychological problems. The ailments like hypercholesterol level, diabetes, hypertension predisposes a person to having an organic etiology for sexual problems. Otherwise, it's mostly psychological in origin.
Right. And we have another question that asks, can hormonal imbalances cause mental disorders like depression and anxiety?
See, hormones whether we call it hormones or whether we call it neurotransmitters or whether we call it chemicals, so to say. Definitely, yes. Whatever changes are happening in anxiety and depression are under the control of these neurotransmitters, so to say, chemicals. So, yes, the imbalance of these definitely cause. See, the classical example is PCOD. PCOD is such a
Yes.
common condition in women, 70% of women have. Okay, so the hormonal imbalance that we are talking about here is progesterone and estrogen. And it is a known factor that the imbalance in estrogen and progesterone predisposes women for anxiety and depression. I'll tell you,
Okay, what?
so many women come to me who have an overlapping diagnosis of PCOD, and as they start
Yeah.
recovering because with their treatment as far as depression, anxiety is concerned, their cycles also start to regularize. The physical symptoms, the emotional symptoms that are associated, which were part of anxiety and depression, which were construed as a part of PCOD, also start changing.
Yes, that's true. Someone just asked, what can a couple do together to have a regular and healthy sexual relationship?
Well, I have a long and a short answer. I think I do. We do not have a time for long answer. The short answer is communication and being honest with your individual selves. If you're honest with yourself and if you can communicate with your partner without the fear that what my partner will think of it, I think that's a good start and that will solve most of the problems.
Right. Okay. I think this brings us to the end of today's session. Thank you so much, Dr. Targe, for joining me. This has been a very thought-provoking conversation, and I'm really glad you were a part of this. Thank you so much.
No problem. Thank you very much for inviting me, Sangamitra. I always have fun doing these sessions because, like I told you, mental health, sexual health, these are some of the most areas which are close to my heart. And it much needed, much needed. More and more talk should be there about these things.
It is. I hope we have more. Thank you. See
All
you.
right, bye bye.
Bye bye.